It's a really great pleasure to have Thierry Van Sta here from the CPRD and the NHS. This, as you know, is the National Health System Data Link program, which is a collaboration of the single payer, single EHR system in the NHS that essentially assembles a variety of different databases to answer a lot of questions with a very functional group under the title of the CPRD, or the Clinical Practice Research Data Link. Emphasis on the link side, which is really about trying to be as minimally disruptive to care, but measuring by pulling together a lot of common databases in the UK to try to answer important questions from prospective studies to surveillance of products, such as the National Joint Registry. Dr. Van Sta is a director of research for the CPRD within the MHRA in the UK. This is the observational interventional data system in the NHS. I've come to work with it a little bit on my own. I think this is an outstanding world-class program, which I think we model for a lot of countries and healthcare systems going forward. So really glad to have Dr. Van Sta here. His research activities are really concerned implementation of randomized clinical trials that can be embedded on routinely collected electronic health record data. So without further ado, Dr. Van Sta.
Thank you very much. Good afternoon, everyone. It's very, very interesting to be here and to hear about all the experiences here. And I have to say, a lot of what I'm going to say is probably reflected by experiences you have here, similar challenges, and also we all see the same opportunities in using routinely collected healthcare data for better research. And the title is Randomized Evaluations of Accepted Choices in Treatment React Trials. So that's what I will talk about, is how can we randomize patients and then follow them using routinely collected data. The first one is disclosures. I work for a CPRD and we receive funding from quite a large number of parties, including pharmaceutical industries. I don't have any personal conflict of interest, but what I have to stress is what I'm saying is clearly my own opinion and not necessarily those of my employer. Phases of drug development, and this is one way of seeing it, and I think most of you will kind of agree with that in some ways, is what we have currently is the kind of and this is Ferrari, a new drug to be launched in the UK. It was developed very well, lots of close monitoring. The GCP inspectors were very happy. There was close monitoring at any time of how Ferrari was doing. And this was done in the Formula 1 healthcare center and then repeated in the Formula 2 healthcare center. I'll show you a patient, Michael S., who basically was using Ferrari. And it was then launched because it was shown in a randomized trial that Ferrari is highly effective and the performance was really very optimal. It was then launched, and you can see a picture here of Ferrari in action. This is on a motorway, and you can see a couple of Ferraris in action. So we kind of move from a highly controlled situation to kind of what's happening out there. And I think this highlights the kind of the dilemmas we face, because the Ferrari trial is a trial with very high internal validity, low measurement error. We're measuring everything, we're controlling everything. But actually, when we then go out there, what is the generalizability? What is our ability to generalize from what we saw in this beautiful Formula 1 and Formula 2 healthcare center to things out there? And that's the real challenge. The regulators, of course, have understood that, and they kind of implemented the spontaneous reporting system you can see there, where you measure all the accidents, but often you don't know the driver, the type of driver. You have very little information about the conditions of the road, etc. But then we epidemiologists, I'm an epidemiologist, we go to work and we do a carefully matched analysis comparing, in this case, Ferrari with Trabant cars, solid Eastern German cars. We do propensity score matching or whatever in order to address those questions. There's something lacking, and that's what I think is the kind of the REACT trials, the kind of the pragmatic trials using routinely collected data. And this is just an example of these Ferrari trials, and they're out there. And this is an historic example of celecoxib and rovacoxib. And this is not a criticism of those trials, which were actually well done, but we're missing one thing, is what's the effects of these drugs in routine clinical practice. And we published a couple of years ago an analysis comparing patients in actual clinical practice to those in the trials. And we actually found that the vast majority of patients using selective COX-2 inhibitors would never have been eligible for the main registration trials. And that's, I think, an issue we need to address. So this is the way, what we're trying to, is one piece of the puzzle. This is not the total solution, this is one piece of the puzzle. And this is an article we published a couple of months ago with colleagues in the BMJ, where basically we argued that we should do a lot more pragmatic trials using routinely collected electronic healthcare data. And the idea is very simple. You recruit patients at the point of care, you get the consent, and then you utilize the routinely collected data for follow-up. And we argued in that article we should do much more of those trials. And of course, to highlight, this is not the solution for everything. On the left, you see an article about a phase 1 trial which went horribly wrong. We saw human guinea pigs explode. That was the headline. Clearly, this kind of trial, REACT trial, would not be suitable for high-risk trials. But there's a very good role for it, and that's on the right-hand side. This is a graph that shows you the proportion of patients, or the percentage of patients in a practice, so each dot is a clinical practice, where we measured patients with a COPD exacerbation and how many of them got an antibiotic. And you can see that in some practices, patients did not get any antibiotic for any exacerbation, while in other practices, all patients received an antibiotic. And in some practices, it depends. So actually what it shows that if you're a patient, you go to one practice, you may get the intervention, you go to another practice, you don't. There's a variability and heterogeneity between practices. And it's not to criticize general practitioners for that, because if you look at the clinical evidence, there are no clinical trials conducted in this population. But this highlight, there is this variability between practices and how to do that. So how can we solve that? And the answer, I think, is a randomized trial in this setting. So this is kind of why we're trying to do these REACT trials. One observation, and I'm an epidemiologist, and you can say I'm in midlife crisis, because I actually think that confounding is a real problem in epidemiology. We can't actually solve it using all the propensity matching statistics or other advanced statistics. Of course, there's still a role for epidemiology, but trying to assess, trying to compare two different drugs, it's very, very difficult in epidemiology. So why not have a system where you randomize patients and then you have a systematic collection of data? You don't ask the practitioner, the clinician, to start collecting lots and lots of data, because that will interfere with their practice. So if you have a system using routinely collected data, where all these data will come in anyhow, that will be a very rational way to deal with uncertainties. So what we have is the system which I'm going to describe is where you have an electronic healthcare system and you have linked databases. We identify eligible patients within the electronic healthcare database. We then ask the clinician to confirm the eligibility and recruit a patient, and we then use the databases to follow patients long term. And the whole idea is, and that's the whole, and I've heard that before, is that we have simple trials, at least for the clinicians, and we're trying to integrate them as much as possible with clinical practice. And I've once called them randomize and then forget trials. And it was a misnomer, because clinicians in the research team said, we can't forget about our patients. But from the research perspective, actually it is what you want to do. You want to randomize patients and then basically let practice take its course. If patients stop their treatment, they stop their treatment. That happens. So that this kind of system will minimally interfere with standard care, with standard practice, and that should increase the kind of the utility of those studies. So just quickly about the organization I work for, the Clinical Practice Research Data Link. For those of you who don't know, it used to be called the General Practice Research Data Lake, and we now call it CPRD. We basically maintain the records of about 5 million patients currently, and we get all that data minus the identifiers. And in the UK, and we get the data from general practitioner, they are the central healthcare provider. So, and almost all GPs in the UK use computers for record keeping. A lot of practices don't have any paper anymore. Everything goes into the electronic healthcare data, which of course is very good. And we include about 8% of the population. And what we are able to do is, we know which practice the data come from. We're able to go back to the practice and say, patient 42, can you contact the patient? And if the GP is willing to do that, we have a way back. So that's called pseudo-anonymized. There's a way back to the patient through the system. We also have a system where if a patient doesn't want the data to be shared with us and in the research database, there's an opt-out system. So they can say to the practice, I don't want my data to be seen by anyone else. And then those data won't leave the practice. We've linked the data set using a trusted third party to other data sets like hospital data, death certificate data, and registry, which really adds a lot of value for research. We have some quality standards, so not any practice with any data will be able to provide data, so we're trying to kind of keep that. And also, quite importantly, there's a regular transmission of the data from the practice to us, and currently we build a research database every month. So every month there's a new copy of the research database. So we have two trials I'll mention which currently are ongoing and are live. One is a study comparing two types of statins, simvastatin to atorvastatin, and these are feasibility trials, so they're not huge numbers. This trial, we hope to recruit 300 patients. And we all know that statins are effective in reducing the risk of cardiovascular disease, but we don't actually know which one is better. Most trials are done comparing simvastatin to placebo or atorvastatin to placebo. There are no direct comparative trials. So why not, in this setting, compare the two by randomizing patients? The other study is a study in patients with chronic obstructive pulmonary disease, and whenever they have a COPD exacerbation, then to randomize them between antibiotic treatment or no treatment or no antibiotic treatment. And like I said, there's little clinical evidence for the effects of antibiotics in this condition. So what we have is ultimately, and I'll go into a bit more detail later, is two recruitment models, is what we call the hot recruitment models, like in the COPD study. Patients have a COPD exacerbation, they then need to be recruited immediately, because you can't say to the patient, come back tomorrow, and we then decide what to do. So we have two methods of doing that. Is one, we have a flagging software where a pop-up box will appear at the screen, and it changed. A pop-up box will appear at the screen, and the GP is then notified that this patient may be eligible for a trial. Okay. Go back to the. Yeah, so that's the flagging software. The other one is clinicians can also themselves go to the study website and then register the patient and recruit the patient. The cold recruitment is where you don't actually need to recruit the patient there, and then you can basically take your time. And in this case, what we do is we send a regular email to the clinician of potential patients we've identified in the database with apparently a very high risk of cardiovascular disease. We then ask the clinician to review, and if they can then invite the patient, and then they can go to the website to recruit the patient. So that's the model. And this is a slightly more complex graph where you basically can see the same, but more or less schematic way. You have the electronic healthcare record in the middle, on the bottom. That's where the action is. The clinician enters data. For the trials, we have implemented a system where there's a daily download to us, where we can then screen patients. For example, in the statin trial, if a patient receives a statin today and they were not part of the trial, they will be ineligible and they will be taken off our eligibility list. So we then, in the research database, we create this list of potentially eligible patients, and we, on a daily basis, we update that list. That list is then called kind of the eligibility assessment. That list is fed to the study website, which is external, it's on the web. GPs can log into that, and they can basically start recruiting patients through that. But through that website, we control who gets into the study and who doesn't. Also, we control which GP can recruit and who cannot recruit. If a GP has recruited more than enough patients, the website will be turned off for that GP. If we don't like the GP anymore, we turn off the system. So that's for the kind of the cold recruitment. The study website is quite important. And what they need to do when they go to the study website answers very simple questions about study eligibility, like, did you ever use a statin before? No. Do you have a high cardiovascular risk? Yes. A couple of other more questions. If they've done that, they then click, and the patient is then randomized to either simvastatin or atorvastatin. And it's an open study, so the GP and the patient will know what they've been treated to, what they're being randomized to. In the hot recruitment in the COPD trial, we use a piece of flagging software which we call Impetus, and it's basically sitting on the desktop of the GP, and it's monitoring what's being entered into the electronic healthcare record. So if there's a record of COPD exacerbation being entered by the GP during consultation, and the patient is on our list of eligible patients, LEPUS will merge those two together, and then if the two are okay, a pop-up box will appear, and then the GP will be redirected, if they have time to recruit, to the study website. They can also say, I don't have time, go away, so it's optional. But that's the flagging system we have. So then, like I said, patient is recruited, they have to sign consent forms, and randomized to various treatments. So then you can create, of course, your database, and we use the linked data sets to kind of get a fuller picture of everything that's happening. So you can then follow patients long-term for, let's say, a heart attack. In the statin trial, we can use data from the GP data or from linked data sets to measure heart attacks, and that can be done for a very long time. We can also use this database to compare our trial patients with the non-trial patients. We can do drug safety monitoring because we have all those data coming in on a daily basis. So, of course, what I said is the treatment allocation is not blinded. They are not blinded studies. Potentially you could do it, but of course you would add a lot of complexity to the system to do that. To get placebo tablets to all the practices, to all the pharmacies across the country would be a lot of work to do that. So these are open studies, and the argument is that if you're talking about a heart attack or death or major clinical outcomes, it probably shouldn't matter too much whether the clinician knows the treatment allocation or not. And especially if you make the trial so simple, they always will forget about the fact that the patient is in a trial. You can also measure persistence. You can measure whether simvastatin or atorvastatin is better in keeping patients on treatment, because we all know that when we start a chronic treatment, the vast majority of patients will stop at some point in time. So improving persistence would be really good. We also wanted and are trying to collect additional data. And in the e-lung study, there was a very strong push from the funder to start collecting quality of life data. And we ended up with a nice device, which is an electronic device where the patients can enter on a daily basis their symptoms of COPD exacerbation, and they can also do a lung function test. And I have to say, I mean, I was very keen on doing that, but it added quite a bit of complexity to the whole system, and the GPs have been complaining about it, saying it's far too complex, because they needed to be doing training on the device, etc. So it's possible, but there's always the downside of complicating the design quite a bit. Also, in the trials, we do a daily check of side effects, whether there's a Stephen Johnson's reported in the electronic health records. We check for any information on side effects entered in the specific side effect fields. And if we pick up something, it's been reviewed and then reported electronically to the regulator. Now, the only thing with the electronic reporting is they just changed their system, so we have to redesign the kind of the mapping to that. But anyhow, that's a temporary problem. We can then do a monthly analysis comparing patients in the trial versus non-patient. I'll show you an example of that, which also highlights the challenges we face. And on the top you see, this is done a couple of weeks ago with more recruited patients now. You can compare the patients in your trial, that's the second column. You can compare them to patients in the same practices but not recruited in your trial. And you can compare them to all the practices that are not participating in your trial. And you can see here, this is quite in a way disappointing. We've managed a couple of weeks ago to have recruited 10 patients, a lot of work. But look at that, 260 patients in the same practices that were not participating in the trial. And look at the other side, we have over 2,500 patients in non-participating trials. So in essence, there are lots of patients out there who could have participated. And I once read somebody said, if all the patients in a country were to participate in a stroke study you could run trials very, very quickly. We could recruit, if I have a simple system, you could recruit patients in a large statin trial within a week or 2 weeks. So that's, I think, is an interesting. Just one thing to note, and I'll talk about that later, is about 1 in 5 patients were using amlodipine, and I'll come back to that later. The other analysis you can do, and of course they are not very interesting at the moment because we have 0 cases, you compare your trial patients to your non-trial patients, you can compare your practices to your non-practice. There's a lot of analysis you can do. Of course, you would drown in data at some point in time. So this is an important question. I was asked, what about data quality and in the electronic healthcare record? And it's quite interesting. I mean, I went to a training in how to prepare for GCP inspections a couple of days ago, and the discussion was about electronic healthcare data. And the person very experienced in GCP said, oh, what you need to do is you need to print it all out, then hand it out to the investigator who will then sign it. And I kind of almost fell off my chair of doing that. And it reminds me a little bit of an experience, a personal experience. I had a couple of weeks ago. I had to go to the hospital to collect a prescription for one of my members in the family, and I had to look for the record because they all have paper records in the hospital there. It took them an hour to find the record. That one person was looking around everywhere in the hospital to find it. So then they looked in the records and said, oh, I'm not quite sure what it says here, but I think it says treatment may be referred to the general practitioner, because that often happens in the UK. We're not sure, but we'll ask the clinician tomorrow. So then I went to my GP, and said, my name is this and this. Type in, yeah, do you have a prescription? No, we don't. 5 seconds. And it was all done. The GP knew exactly where the data were. There was no problem. So talking about data quality, I think we need to focus slightly broader than just electronic data. There's also always an issue with paper records as well. But we have unique opportunities with electronic data. Is one of the things, like we can use linked data. Like in the statin trial, if you want to measure heart attack, you can do that using the GP data. You can use the hospital data, admission data for a heart attack. You can use data from a disease registry. And if the patient died because of a heart attack, you can use the death certificate data. So there's a lot of information coming in. That information will come on even after the end of the study. You can always go back to the clinician and say, yeah, we found this. Can you confirm that? You can send them an email with a link or whatever, and they can then confirm what you saw or didn't see. So there's always that ability as well. You can also go back, if possible, to the patient and say, are you willing to give pharmacogenetic information or whatever. So there's a lot of scope of doing that. And lastly, you can also ask a blinded person to look at all the data and determine whether this was indeed a heart attack. So there are various ways of doing that. And a more generic way, of course, is also measuring systematically the data quality across practices. And this is the bottom graph is kind of what we're trying to do is measure a lot of different things, of how things are being measured in practices, and trying to find whether some practices consistently record better data than others. And this is an example of the distribution of HbA1c recording in patients with diabetes over time. And this is per practice. So this is a box plot of practice quality. And you can see it dramatically increased over time. And that has to do with some payment incentives where GPs are getting paid. We tried to use a whole series of measures with the idea we would be able to find bad quality practices, and actually we didn't. Some practices were good at some things and bad at other things. But having said that, there's some scope of trying to measure systematically data quality. So what are the challenges and opportunities? The opportunities are electronic healthcare data are there. There are a lot of clinicians are using them and are starting to use them. And the ability to link with other data sets really increases the value of the data quite a bit. Challenges are kind of the hospitals, at least in the UK, not all of them use paper. You have data on admissions, but they are very similar. They are not very detailed data. But fortunately, there are also disease registry, which contain a lot of large wealth of data. And if you're able to link with them, that clearly adds value. The challenge, and we've touched about that yesterday and today, is medical data are not uniformly recorded and coded, etc. And the question is, will they ever be? Because part of clinical practice will be patients come in, you're not certain what's happening, some data being entered, and over time the picture evolves. So it is not always clear. Linked data sets, the whole issue is, I mean, you have different coding dictionaries between data sets. And in IT world, there's this concept of seamless semantic interoperability, that you can move data from one set to the other by having similar coding dictionaries, similar semantics, etc. I'm not sure actually that it will ever happen, because data are being collected for different purposes, for different reasons. So even if your contents are the same or appear to be the same, they're being collected for different reasons. A heart attack, for example, if the patient dies at home, the hospital won't know about that. And all those things you need to take into account when you start looking at linked data sets. And also things change over time. When you have worked with linked data sets and regularly, suddenly there's a change in the data structure because something changed. So that's a challenge all the time. We've had some issues with this flagging system, Lepis, because once you start to introduce new IT systems, there are always issues with loading the software, firewall issues, but hopefully we've gotten through that. So we've had some issues with integrating with clinical care. This idea was to make it as seamless as possible, but we had some issues. One is the statins are not always used by GPs according to the license, the official license, and of course when you talk about good clinical practice, it used to be the case that if it was outside the license, it was considered a high-risk study, which makes it a bit complex. So we're trying to amend our inclusion criteria according to that. Things are slightly moving there, but it was a problem initially. Big issue was prescribing guidelines. One of the issues we faced is there's a price difference between simvastatin or atorvastatin, or there used to be, and a lot of local NHS organizations require GPs to use the cheap one, simvastatin. So they have all these prescribing rules. So if GPs want to prescribe atorvastatin, they are basically phoned up by the local NHS organization saying you can't do that. And even for research, there's no exception for that. So we now have the situation that in some areas we have to switch, the GP has to switch the patient back after 3 months, which is the official end of the study, back to simvastatin, which of course, from the scientific perspective, it undermines the study because you want to measure things long term. So that's something, and we tried to argue with ethics saying it would be unethical, but the ethics committee said, oh, that's fine, so they accepted that. Prescribing habits always is difficult. It's all issue of equipoise. And the other one is, I'm just touching on the safety information. I mentioned that about amlodipine used about 1 in 6 of patients, so this is quite a bit. Very recently, the UK regulator issued a warning about not using high doses of simvastatin with amlodipine. So a lot of GPs were then switching to atorvastatin, and is saying to us, if the patient is using this amlodipine, we don't want to give simvastatin anymore. So we basically then, first of all, looked in the database, and we found over 100,000 patients with CPK measurements during statin treatment. And we found that a very small minority, a small proportion of patients indeed got high CPK levels, but we didn't find any association with amlodipine. But we went to the data monitoring committee and they said, no, you need to amend eligibility for that. So we now are in the process of excluding amlodipine users. So stakeholders, I have to speed up a little bit, but the key bits from the key stakeholders are the patients and the clinicians. Patients, we have patient representative on the trial steering committee who are extremely supportive, and we're doing work on trying to get feedback of patients. And one of the challenges we've had is we want to interview patients who refused participation, and then in itself was a very interesting challenge to convince the ethics committee of how to do that. And that's, I hope we were able to get patients who refuse. Clinicians and feedback is kind of, some of them are very interested, but some of them say it's far too cumbersome to fill out this form and that form, to do this approval. We asked them, for example, to do training in the protocol. So why do we need to ask to do a protocol training for GPs and how to prescribe a statin? They do that all the time. So that's one issue there. But on the other hand, the positive thing is there is some statements in the ethics guidelines for clinicians that say there's a duty for them to resolve uncertainty. So I think there's a way forward. Resources, there are lots of resources. The IT systems took a lot of time to develop, but we're trying to develop generically. So the model we've had is we have an external study website where simple information can be added. We didn't want to have the model of changing the electronic healthcare record with forms in there because the vendor wasn't too keen on doing too much work for us, so we therefore decided to kind of keep it on the study website. We have a nice system, I think, for daily processing, and that all works. But if you think about these trials, I mean, they can be done fairly cheaply, but the biggest cost at the moment are for staff costs to get all the approvals done, and also the cost to reimburse the clinician. So if we're able to move to a scenario where clinicians would see it as part of their work to do the work, and we keep it simple for them, those studies can actually become quite quite cheap. Last couple of slides is basically the challenges. Like I said, the research governance is really, really complex. We had to do a lot of work to get approvals. We need to train GPs, and like I said before, why do we need to train GPs in how to give statins? An interesting comment about the consent procedure, the consent form. The ethics committee came back when we submitted it, and they said this is the skimpiest form we've ever seen. And I thought, oh, that's good, because most of the evidence suggests the shorter the form, the better. And I also thought it makes sense because the only thing we're changing is the randomization. One statin or the other, that's what we're changing. No, as they weren't in agreement with that, so we had to extend our consent form. Things like if you're a private health insurer, if you have private health insurance, tell them. And we've asked the private health insurance institute, said, do you need to know about it? And they said no. But the ethics committee said, no, you need to put it in there because if there's an insurance company from China, let's say, they may not abide with the rules of this Institute of British Insurers or whatever they're called. This other issue of prescribing guidelines, there's a lot of prescribing guidelines. It's very, very difficult, increasingly difficult to do something which tests those guidelines because a lot of organizations will say, but that's the guideline, you can't go against that. So it's a reporting requirement. That's the question I have, is we have to report things within 7 days and 15 days. And I've asked regulators, why do you need to know within 15 days? We can give you monthly reports, 3 monthly reports of the incidents, so you can know everything. And they said, no, your study could make a difference in the risk-benefit ratio. And I kind of said, but what's the chance of that happening? Statins are used by so many people. Why do you actually think a 15-day report will make a big difference? And that, of course, adds to the complexity of GPs having to fill out forms, etc. Clinicians, I think, is important. What we tried initially, we went to the Royal College of General Practitioners and said, are there any points clinicians can get by participating in research? And they said, no, there are none, which I think is really not good. And the last thing I think is important on policy is that actually what I really would like is that clinicians come to us and say, we want this study to be done. And we say, yes, we have the infrastructure to collect our data. You collect your colleagues, you talk to your patients, we organize the data collection. That, I think, is kind of the ideal model. Instead of us, me as a researcher, coming to them and say, do you want to do this for me? That, I think, ultimately is where we need to go. So, yeah, the good and the bad. So it does work. I think we have engaged clinicians. They're interested. But on the other hand, I don't think simple trials yet exist. It is all very, very difficult to get them going. And also, disappointingly, most clinicians don't participate. And we're trying to find out why, but I can understand to some extent, because what we ask them is not simple. They need to fill out a lot of information. So where do we go? I think, yeah, the questions, and I think a lot of us have been discussing that, is we can make these trials work, they work, but we need to kind of simplify the research governance. And I think what really is important that we understand there's a cost of not doing studies. Currently, if you have a COPD exacerbation, it depends who you visit, whether you get an antibiotic or not. We should know whether it works or not in order to improve healthcare. So, and the other thing also is quite important. We have this segregation, like we discussed before, between research and daily practice and clinical practice. Trials like this can directly benefit the patient. If we're able to find out quickly whether antibiotics work or not work in COPD exacerbation, the same patients who are participating in our trials will benefit from that in a couple of months. Because most of them, unless they die, will still have COPD. So I think that's an important lesson I think we all need to take on board. So my last kind of acknowledgement, there's a lot of people being involved in these trials. I mean, there's a team at CPRD who works on that, a lot of co-investigators. Syrian Chalmers, he has been the inspirational head of the trial steering committee, and also kind of recognize the GPs and nurses, patients, and also the funders, the Wellcome Trust and the Health Technology Assessment. Thank you very much.